The human spleen is a highly active lymphoid and reticuloendothelial organ positioned deep within the body's left hypochondrium. Its long axis aligns exactly with the 9th, 10th, and 11th ribs, with the bulk of its mass resting directly along the 10th. Because of this tight structural alignment, any fracture involving the left 9th, 10th, or 11th ribs requires immediate clinical investigation for underlying splenic injury. When pathology causes the spleen to enlarge, it cannot expand inferiorly. Instead, splenomegaly forces the organ to grow medially, projecting directly toward the umbilicus. This trajectory is dictated by a rigid anatomical floor. The phrenicocholic ligament acts as an impenetrable physical barrier that blocks any downward expansion. As the organ pushes medially into the accessible abdomen, clinicians can physically palpate a distinct notch on its inferolateral border during a standard abdominal exam. Defining these exact topographic boundaries dictates how blunt trauma is assessed, how physical exams are interpreted, and how surgical access is ultimately planned. The spleen operates as a dynamic processing center, simultaneously executing 4 distinct physiological mandates. First is its immunological function. It generates critical antibodies and serves as the primary systemic defense against encapsulated bacteria. Second is its filtration, or graveyard function. Macrophages continuously identify and remove senescent, or poorly functioning blood cells as they navigate narrow endothelial slits. Third is its hematopoietic function. This is primarily active during the 3rd to 5th week of gestation, but it can dangerously reactivate later in life during severe myeloproliferative disorders. Finally, it serves as a massive biological reservoir, maintaining active storage for circulating red blood cells, white blood cells, and platelets. Excising this organ removes 4 biological processing systems at once, forcing the entire systemic circulation to rapidly compensate for the deficit. Despite the vast array of diseases that target the organ, acute physical trauma remains the absolute most common indication for a splenectomy. Secondary surgical indications include hematological disorders like hereditary spherocytosis, immune thrombocytopenic purpura, and hypersplenism. It is also removed for oncological clearance in gastric or pancreatic cancer and to relieve left-sided portal hypertension caused by splenic vein thrombosis. When neoplastic disease is the trigger, the pathology usually falls into one of 2 categories. Hemangioma is the most common benign tumor, while lymphoma is the most common malignant tumor. Surgeons must also differentiate between distinct types of splenic cysts. Pseudocysts are non-epithelial false cysts that follow trauma and typically resolve spontaneously. True cysts, like the echinococcal hydatid cyst requiring albendazole, or the squamous-lined epidermoid cyst, demand active management, with excision required for any cyst exceeding 5 centimeters. Distinguishing ectopic tissue is equally critical. Spleneculae are congenital accessory spleens near the hilum that will cause ITP to recur if missed during surgery. Splenosis, however, is an acquired condition. It is the autotransplantation of normal splenic fragments onto the omentum or bowel surfaces following a traumatic rupture. Misidentifying these tissue implants directly alters patient outcomes, determining whether a patient suffers a relapse of their hematological disease or retains a baseline of functional immune protection. The splenic artery originates from the celiac trunk, snaking along the superior border of the pancreas. The splenic vein merges with the superior mesenteric vein to form the portal vein. This junction dictates surgical design. Distal splenorenal shunts are selective, while proximal shunts are non-selective. This high-flow network is vulnerable to mechanical failure. The splenic artery aneurysm is the most common visceral artery aneurysm, typically driven by pancreatitis, physical trauma, atherosclerosis, or pregnancy. If this aneurysm ruptures, massive intraperitoneal bleeding severely irritates the diaphragm. This triggers care sign, intense referred pain striking the left shoulder tip. CT angiography is the diagnostic standard, and endovascular therapy is the modern first-line intervention. Flow interruption creates dual ischemic threats. Splenic infarcts present with pleuritic or shoulder pain and show as hypodense areas on contrast-enhanced CT, typically managed conservatively. A splenic abscess, however, targets immunocompromised patients, revealing necrotic debris that mandates immediate pigtail catheter drainage. The low-pressure, high-volume mechanics of this regional vascular network leave the organ highly susceptible to both catastrophic rupture and localized tissue death. The operative sequence for a splenectomy requires strict adherence to anatomical planes, always beginning with the careful identification and mobilization of the organ. First, the surgeon divides the avascular splenic and splenocolic ligaments. The approach then shifts to the vascular tethers, the gastrosplenic ligament, containing the short gastric vessels, and the dangerous splenorenal ligament, which houses the primary splenic vessels and pancreatic tail. With the boundaries mapped, surgeons clamp and control the central hilar vessels, finalize the division of the short gastrics, and extract the spleen. Confusing the contents of the gastrosplenic and splenorenal ligaments directly drives severe, life-threatening intraoperative hemorrhage and glandular trauma. Immediate intraoperative risks remain high for the patient. If short gastric vessels are improperly ligated, the adjacent stomach wall suffers sudden ischemia, leading to localized tissue sloughing and severe hematemesis. Because the pancreatic tail is embedded within the splenorenal ligament, accidental injury during extraction causes amylase-rich fluid to pour directly into the surgical drains. Beyond local tissue damage, severe left-sided incisional pain restricts deep inspiration. This mechanical limitation causes left lower lobe atelectasis and pneumonia, making it the most common general postoperative complication and mandating immediate chest physiotherapy. Post-surgery, a graph shows a simultaneous surge in circulating red blood cells, white blood cells, and platelets. Platelets crossing the 10 lakh threshold spike thrombosis risk, requiring prophylactic aspirin. While counts stabilize, permanent peripheral smear markers emerge, including Howell-Jolly bodies and basophilic stippling. The localized mechanical trauma of the operation rapidly forces the entire circulatory system into a reactive state that demands strict clinical management. The most critical, highly lethal long-term complication a patient faces is overwhelming post-splenectomy infection, or OPSI. The body is highly vulnerable to encapsulated bacteria. Streptococcus pneumoniae is the most common causative organism, followed by Haemophilus influenzae and Neisseria meningitidis. The statistical risk of this infection is highest in pediatric patients and peaks aggressively within the first 2 years following surgery, though a lethal risk persists for the remainder of the patient's life. The original indication for surgery dictates the exact level of danger. The risk of OPSI is significantly higher following a hematological splenectomy compared to a trauma splenectomy. Severe trauma often results in splenosis, leaving behind scattered nodules of functional splenic tissue that provide residual immune protection. Physicians execute a mandatory vaccination protocol: pneumococcal and meningococcal every 5 years, Haemophilus influenzae every 10 years, and an influenza vaccine annually. Timing optimizes the antibody response. For elective procedures, these vaccines are administered 2 weeks prior to surgery. In an emergency trauma scenario, they are given on postoperative day 1 or 2. Removing the spleen physically solves the immediate pathology, but the patient's long-term survival is completely dependent on lifelong immunological vigilance.